Rainbow family. I'm Sarah, your host and barista on Gender Espresso. Now this topic is a pretty heavy topic, so there's a lot of information, but I'll try not to make the videos too long. The transmasculine, masculine, non-binary procedure that I'm about to speak on is metoidioplasty, primary urethral lengthening, vaginectomy, plus or minus scrotoplasty. I think the best way to understand this procedure is to break it down into all the different components of it. So let's start with metoidioplasty. Like a simple metoidioplasty, the goal is still to lengthen the phallus as much as possible, and this involves dividing the suspensory ligament, the ventral chordae, which is like the attachment on the underside of the penis, and help release that so that it can extend as far out as possible. Now, like a simple metoidioplasty, the result as to how effective this whole operation is still quite dependent on the patient's body habitus, meaning how much tissue they have in like the mons and pelvic region. So lower weight patients will have an easier time with genital show, right? There's less getting in the way of showing their genitals. Now, having good growth because of the response to testosterone is very helpful. However, the phallus in this case isn't as tubularized as it is on a simple metoidioplasty. And what happens is that because of the primary urethral lengthening, meaning creating a conduit using labia minora as the tissue for the new urethra that goes from the tip of the penis all the way to the natal urethra, that bit of tissue from the new extended urethra tends to have a little bit of bulk to it that makes it look like a bit of a veil rather than a purely tubular penile structure. Most patients don't mind that because they are able to pee from the tip of their penis. And again, depending on the response to testosterone and how large the phallus is and how much it can be extended surgically, the majority of patients are able to stand up to pee, which is one of the goals of having metoidioplasty with urethral lengthening. Now, the next portion of it is the vaginectomy. I perform the vaginectomies. I have been trained for it. And so the way I remove the lining of the vagina is by full excision of it with cautery. The alternative to this, which is not the way that I perform it, is fulguration. And what that means is taking the cautery pen, which is called the bovie, and basically burning the lining off. I don't like that, and in my opinion, it's like I would have a hard time burning it consistently at the right thickness, so that if there's any partial sort of burn to the vaginal lining, the deep end of it will survive. And so it is known that mucus cysts from vaginal lining cells that have survived the fulguration or the burning of it may cause basically bubbles of mucus inside the pelvis. I think that small ones probably don't cause any problems, but I have spoken to other surgeons where they have had to actually go back in and excise a symptomatic or a large vaginal lining mucus cyst. The chances of that happening on a full excision type of surgery is not zero, but it is much, much less. I have to say that so far, no one that I know of anyway has had issues with mucus cysts after full excision type of vaginectomy that I have performed. A common question is whether someone has to have a vaginectomy for a metoidioplasty with urethral lengthening, and the answer is no. I personally do not do primary urethral lengthening without the vaginectomy, and the reason is that I'm not willing to accept the higher risk of complications, urethral, urinary complications such as fistula, strictures, and poor wound healing associated with doing this type of reconstruction with preservation of the vagina. So I choose not to do it. Plus, I don't want to put patients through an almost double risk of these types of complications. In general, urological complications like the ones I've talked about, it can be up to about 33% with metoidioplasty, urethral lengthening, and vaginectomy. But without the vaginectomy, it jumps up to 60%. So basically it doubles. The risk doubles, and I'm just not willing to take on that responsibility, but also put it on my patient to have to kind of work through that. So there are surgeons that do it without the vaginectomy, and so I think some of the centers that do offer it, you'll just have to seek those centers out and ask them what their experience has been and what they do to help mitigate or lower the risk of that happening by preserving the vaginal canal. The next step in that series of procedures is optional, whereas for me, vaginectomy on my patients is not optional. One thing to also remember is that you can't leave the uterus in place without a vagina, right? There's no outlet to the uterus. So in order to have metoidioplasty, urethral lengthening, and vaginectomy, you would also have to have a hysterectomy either at the same time and have the hysterectomy performed by a gynecologist during the same surgery. They would go first and then I would follow, or you just have it done months prior to the surgery. You do not have to have oophorectomies or removal of ovaries, whether it's both or just one, in order to have this set of procedures that I'm talking about. That's regardless, and that is a conversation between you and the gynecologist regarding fertility and also everything that goes along with ovaries. The last portion of this set of procedures is the scrotoplasty. It is an option, that's why I said plus or minus scrotoplasty, because not everybody wants or needs a scrotum to be who they are. I use the labia majora to create the scrotal sac. There are many well-described methods, surgical methods of creating a scrotum. I follow the one that I was taught and that I have been successful in performing them. And so, without getting too technical, it's basically an anteriorly based flap type of scrotoplasty. So with my approach, which is a rather common approach to scrotoplasty, the perineum is lengthened and our patients have that flat spot where all guys are flat. So how do you pee afterwards? So also as part of the procedure, I place a suprapubic tube, which means it is a catheter that goes through your mons right above the pubic bone and straight into the bladder. And so there's a balloon holding it in place, and you pee into a Foley bag for about 2 weeks minimum. There's also a Foley catheter or a urinary catheter running through the new urethra, the extended primary urethral portion of it. But that one is capped. It's basically serving as a stent to keep the space open so that the new urethra doesn't collapse on itself and come apart or scar together. It seems obvious that no one likes any of those catheters because they can cause a lot of bladder spasms and they are uncomfortable, but they are absolutely necessary. I call the suprapubic tube the lifeline of a metoidioplasty primary urethral lengthening, because that's the most secure way to ensure that you are voiding. You cannot not void, obviously. We as providers are aware that these catheters, these bladder catheters, are very irritating. So we do give you medications to help you just reduce spasms and help you get through that period of needing urinary diversion. You are on antibiotics the whole time while you do have the urinary catheter because infection is a possibility. You have tubes going straight into your bladder. So make sure you take them according to how your surgeon prescribes them so you don't end up being sick from urine infection. And now for recovery. I will say that it is pretty hard on patients undergoing this specific set of procedures, mostly because of the catheters, but there's just a lot going on down there in terms of reconstruction. So it's very understandable that it's a bit painful. So the timeline of recovery is also longer because it is a major bottom procedure. I keep patients in the hospital 1 to 2 days, and then you go to your home, your Airbnb or hotel to recover for the rest of the time. At about day 10 to 12, that's when I pull the Foley catheter that goes through the neourethra and into the bladder. And so it's a catheter that's down below that wasn't connected to anything. And so we pull that in the office and we have you pee through your new urethra and your new penis. This is to make sure that your urethra is intact and it's patent and urine's coming through. It also lets us know how well the urethra has healed along the entire track of it. And so if you have a fistula, meaning a hole or a defect along any place on the urethra, then urine would leak through it, not just through the tip, but it would also drip from the underside. And so it is helpful for us to see that and be aware of it so we can basically deal with it. If that were to happen, then what that means is that it delays the removal of the suprapubic catheter. Again, that's like your lifeline in terms of urination. And so most small fistulas heal on their own. And so it may be 2 extra weeks on the suprapubic tube, sometimes even longer. I have had to fix fistulas that haven't closed on their own with extended diversion, meaning extended use of the suprapubic tube, but most of them do close on their own. And once it does close, then the suprapubic tube comes out. So ideally, timeline 10 to 12 days, the Foley catheter comes out. 2-3 days later, as long as you're peeing okay, emptying your bladder, and there's no obvious evidence of a fistula, then we pull the suprapubic tube and you go home without any bladder catheters and you're peeing through your new urethra.